Hi, and welcome to those of you who are just joining us. We're going to wait a few minutes to get started to let people log on, so just hang with us for a few. Hi, for those of you who just joined us, just hang tight for a minute or two while we let everyone who's planning on joining us log on, and then we'll go ahead and get started. Alrighty, I think we'll go ahead and get started now. For those of you who have not joined us previously, just a reminder that this is a webinar for the UW School of Public Health community. So if I talk about policies or sort of ways that we're approaching school or work, keep in mind that I'm speaking from the perspective of the School of Public Health. So if you are primary in another school at UW, or if your primary employment is actually someplace other than the University of Washington School of Public Health, then you should probably check with your supervisor to find out what's the situation for you. In terms of protocol, we use the Q&A window rather than hand raising or the chat function. So if you have questions, feel free to open up the Q&A at the bottom of your screen and put them in there. Today, our exciting news is we're delighted to welcome back Carey Farquhar, who's our Vice Dean for Education and also Professor of Global Health, Medicine, and Epidemiology. Carey spent the last 6 months in Geneva on a special assignment with the World Health Organization, and she's going to share more about her experience in today's webinar. And she'll also provide some updates on our back-to-school planning. And at the same time, I want to say a huge thanks to Stephanie Farquhar, who is no relation to Carey, but they happen to have the same last name. Stephanie did a tremendous job filling in as Interim Associate Dean for Education while Carey was away, and helping us navigate through what has really been a truly unprecedented instructional situation over the last couple months. We also have providing updates today, Lisa Manhart, who's our Associate Dean for Research and a Professor of Epidemiology, Uli Haller, who is the Assistant Dean for Finance and Administration, and then, as I mentioned, Carey on Back to School News. I wanted to give you a brief update about our new format and schedule for these webinars. As you have noticed, hopefully, we start at 3 o'clock now, so we condensed it down to an hour. And we are also holding the webinars every other week in the absence of some really critical communication that needs to go out. So if there's an emergency, obviously we'll have we'll put something out, but otherwise it's every other week. And we've switched around the order of things. So we start with COVID updates from me, and then we'll have COVID updates from the Associate Deans at the very beginning, before we go into our special topic and guest speaker. And the reason for that was that we heard from some people that they wanted to check in just for the updates, but they didn't necessarily want to stay for the entire program. So this makes it a little easier if you're just there for the updates. The other sort of change is that we are working on trying to get a schedule organized for the whole summer, so that you can look at the webinar website ahead of time and find out what the topics will be, so people can plan ahead, because we know people are sort of in and out over the summer. So if you have suggestions for topics that you would like to hear about, please feel free to send those to me. We're very open to suggestions and just trying to get everything planned at this point. So it's a good time to suggest them. So in terms of our updates, worldwide today we passed the 15 million mark in total confirmed cases, with global deaths totaling more than 619,000. And of course, as is always the case, our hearts go out to all those who have lost loved ones to COVID-19, or who have loved ones or who themselves are sick with COVID. Nationally, we're approaching 4 million cases with more than 142,000 deaths. Last Thursday, we hit a record of more than 75,000 new cases reported in a single day across the nation. Deaths had been trending down for a while, but have started to rise again. And some regions are continuing to roll back by closing bars and beaches. Here in Washington State, as you know, the governor has put a pause on the reopening process. You should have gotten also an email today. We'll talk about it in a little bit about plans for UW for the fall from Anna Murray. More states are mandating use of masks. Many of us were excited to hear that the President of the United States actually tweeted that he recommended people wear masks. So we're happy that he's on the bandwagon. Better late than never. And but nonetheless, some of the besides the increase in cases, the other thing that's disconcerting right now is that we're seeing widespread reports of delays in getting test results. Those haven't been too severe here in the Seattle area. We're incredibly fortunate that UW Virology has really good throughput and really good turnaround time, but many other parts of the country are experiencing significant delays. In Washington State, the Department of Health is currently reporting 1,465 total deaths, over 5,000 hospitalizations, and over 48,000 confirmed cases. So far in the state of Washington, we've had over 840,000 tests with a positive rate of total of 5.8%. And as always, encourage folks to look at both the Washington State Department of Health dashboard and also Public Health Seattle and King County's dashboard for up-to-date information about how we're doing, both in terms of cases, but also in terms of metrics in testing and healthcare capacity. So in the latest situation report from the State Department of Health, the Institute for Disease Modeling, and the Hutch that was released last week on Friday, public health experts described what they refer to as an explosive situation in Washington State. We look very similar to where Florida was about 3 weeks ago, and obviously we do not want to continue along that same path. Per that report, transmission has steadily increased or accelerated across the state since the start of July, and they warn that that will continue to go, it will continue to increase unless concrete steps are taken to stop the spread. On July 14th, Governor Jay Inslee paused Washington's phased reopening plan through July 28th. He's also announced tighter restrictions on social gatherings. Starting this week, there's now a 10% limit on gatherings on counties that are in phase 3 of the governor's Safe Start plan, and the 5-person limit remains in place for counties that are in phase 2. That includes King, Pearson, Snohomish. And based on conversations I've had with a couple of folks this week, I guess I would just add to that a sort of not too much of a fine point, but an important point that I think a number of people missed when they first looked at the Safe Start reopening plan is that for phase 2, we have a 5-person limit, but it's per week. It's not per event. So in phase 2, we're really supposed to be trying to restrict our interactions to just our household and a small number of additional people each week. In addition, the Washington Interscholastic Activities Association announced yesterday that high schools won't be playing football until this spring. Updates from the School of Public Health and the University of Washington campus. Literally right before we came on this webinar, an email came out from Anna-Marie Tause, our president, and Mark Richards, our provost. So if you haven't looked at that yet, that talks about sort of what we're experiencing and the implications for fall, indicating, as you might expect, that if we continue on the trend that we're on, we should expect fewer in-person classes in the fall, if at all. As hopefully many of you saw, the U.S. government last week rescinded the rule that it had proposed about international students. So it is our understanding that continuing students will be allowed to stay in the U.S. or return to the U.S. For either online or in-person classes, and they will not be required to register for an in-person class to maintain their F1 status. And continuing students who wish to remain outside of the U.S. for autumn quarter and take classes online will be allowed to maintain their F status as long as they continue to follow visa regulations. The University of Washington is seeking further clarification about online course eligibility for new incoming students entering the U.S. for autumn 2020, and so you should expect more updates both from Central and from us about that if you are one of the students who's affected. And I would say, even though that proposed policy was rescinded, it still was really traumatic for us as a community, and I'm sure for the many international students who are attending U.S. colleges, are planning to attend them this fall. And we recognize that there's a whole host of other challenges as well that include travel restrictions, ability to get visas, limited flights, et cetera. So we continue to monitor the situation closely and to continue to advocate for our international students, and we'll continue to share updates with you as we have them. So with that, I'm going to turn it over to Carey to give some more detailed announcements about back to school. Carey.
Thank you very much, Hilary. I'm trying to start my video. There we go. Thank you very much. It's wonderful to be here. I think as Hilary may have already said, I'm Carey Farquhar, Vice Dean for Education, and just back from Geneva, where I spent 6 months with WHO. Today's updates for back to school include what Hilary just mentioned about the university-wide announcement. I think one thing I'll just emphasize there is that they've set August 7th as the date when they will have finalized the plan. So that's a good date to kind of look forward to. On our part, in the School of Public Health, the vast majority of courses will be offered remotely. And I think that's important for all of you making plans to know. Or as importantly, is that if a class is being offered in person, we will be offering a remote synchronous version of that course. We are currently creating a communication that will be out later this week or early next week that outlines this in more detail. The other big announcement on a very positive side is that we have 2 students from the School of Public Health who won the prestigious Bonderman Fellowship Award. And this allows these students, the recipients, to travel the world for 8 months, which might not seem like such a great idea now, but they're not scheduled to start for another 6 months or so. Fortunately, they have no strings attached. It's really an amazing opportunity. So I'd like to congratulate Erin Lee, who just completed her Master's in Public Health in Health Services, and Jewel Towns, who did an MPH in Global Health. And you'll be able to read more about them in an upcoming newsletter from the school. So thank you.
Thanks, Carey. So Uli, we're going to turn it over to you to give some updates on back to work. And in honor of that, I'll note that I'm showing behind me, I'm not up on the roof of our new building, but the picture that I have behind me is from the roof of our new building. So Uli, over to you.
Good. Thanks. I was just going to say that that's not a random picture behind Hilary. That is the new building. So, or at least the view from the new building. Back to work, I'm calling back to on-campus work because I think everybody's been working. It's just where we're going to be working from. At the moment, other than critical employees and anyone with tasks that can only be done on campus, we're still asking everyone to stay home and work remotely. Having said that, coming up and starting next week, many of you are going to be asked to come to campus over the next 2 to 3 weeks to pack up your offices, and then a few days later to come to the new building and unpack your office in your new place. I just remind you that as you do that, all of the campus protocols apply to old buildings and new buildings. It's, you know, wearing a mask, doing your daily attestation every time you come in, maintaining appropriate distance, and in many cases, you'll see we're staggering the packing and unpacking to limit the number of people who are in a given space at any time. And finally, as always, if you are sick, please do not come in to work. And if that means that you can't pack up, you know, let your administrative team know, and we will figure out a way to pack up your things or to unpack your things. You know, having sick people come to campus is not helpful to any of us. And then after we've moved, we go right back to working remotely until, well, hopefully someday when we can come back together. So what does that return to work on campus look like? We're working on that plan right now. Look for details of that plan in the next 3 weeks. There's still some things we're trying to refine about that plan. But the one thing you won't see is a return to work order. We're not going to issue on a given date an order that says now everybody needs to be on campus. Even when we're in phase 4, that's just not going to happen. What we can expect is that we're going to accommodate and encourage remote work for an extended period of time. And so we'll see the return to working on campus be a gradual trend and depend on a number of individual and group factors. Some of the steps we're going to take to maintain a safe working environment when we do come back to campus are things like staggering work days and maybe shifts. So maybe a Monday, Wednesday, or a morning, afternoon, depending on what works out in a given situation. So that by itself will limit the number of people who can come back and be on campus at any given time. Then there are the individual circumstances. Hilary just mentioned it in the opening that, you know, as the schools are going to be remote, doing online instruction through the fall. There are also some childcare option issues for people, whether their childcare centers are open or not. People may be caring for sick or at-risk members of their own households. Some may have dependencies on public transit or other things. That there are a whole number of reasons why not everyone is going to be back in the office at the same time. And we'll continue to take all of those factors into account to really, you know, again, keep people productive remotely and hopefully over time gradually get people back onto campus. So that's the return to working on campus plan as it stands now. Back to you.
Hey, thanks, Uli. Yeah, so we heard Seattle Public Schools announced today, sent out a message very similar to what we saw in the UW community, stating that they're going to be, well, in their case, that they'll be starting online in the fall. So we recognize that's going to dramatically impact people's schedules, and please, you know, communicate with your supervisors. We're encouraging supervisors to remain flexible and accommodating, and particularly if there are people who need to work from home in order to make sure that they have child care and supervision. So with that, I'm going to turn to Lisa Manhart, our Associate Dean for Research, to provide some research updates. Lisa.
Thanks, Hilary. Good afternoon, everyone. I have a couple of NIH updates related to research and then a couple of internal UW updates. In terms of the NIH updates, as I think most are aware, when the pandemic began, NIH provided for some flexibilities for existing federal research awards. And they have just issued a couple of updates. The first is that the flexibility that allows us to continue to charge salaries to grants, even though research personnel may not yet be able to go back to work on campus and work on their projects, has been extended to September 30th. We don't currently have anyone officially in this status in the School of Public Health, but if that should change, please contact your department HR rep if you need to do that, and you'll need to make sure that you document very extensively why this needs to happen. The other flexibilities that they initiated really to make sure that people weren't caught short, many of those have expired. So the flexibilities related to application deadlines, requesting no-cost extensions, the allowability of costs that are not normally charged to grants, and prior approval requirement waivers have all expired. So you need to kind of go back to business as normal for the rules regarding that. That's the bad news. The good news is that they are now allowing late submission of preliminary data. This is allowable for the fall review meetings. So if you have late preliminary data, you can actually add that to a submitted application. Then in terms of internal updates, I just have two brief ones. There's been some talk about additional types of allowable in-person human subjects research. Not surprisingly, this continues to be delayed, given the uptick in cases in Washington State. But they are continuing to work on a new risk score-based approach, and that will eventually be coming out. And then, sadly, we just received a notice actually about the National Security Agency's advisory related to hackers trying to get into university accounts and acquire intellectual property, which usually happens as a result, or they leverage the phishing mechanism. So this is just a reminder to be particularly alert for phishing, and let your IT folks know if you have some suspicious phishing requests. And then last but not least, the Population Health Initiative Equity Research Grants, the deadline's coming up. That's Friday, July 30th. And please contact me if you'd like to request matching funds. We're doing the same matching scheme as usual with a $15,000 match for proposals with an SPH PI and $5,000 match for proposals with an SPH COI. And I'll stop there.
Great, thanks, Lisa. So we have one general question in the Q&A, so I wanted to address that before we head into our special guest part of the webinar. Someone asked whether we could share any updates that we have about unit budget shortfall challenges, and if there are any discussions around faculty and staff having forced furloughs or layoffs. So yeah, I'd be happy to share what we know at this point. So the anticipated budget challenges that we have are related to the state-supported portion of our budget. Back a couple months ago, the governor and the Office of Planning and Budget for the state asked us to model a cut of 15% in our state. This is not just for the University of Washington, this was for all state-funded agencies and organizations, to model a 15% cut and anticipate a 15% cut, which we have all done. For us in the School of Public Health, that's actually correlates to more like a 6 or 7% cut in our budget, because only about a third of our budget comes from the state, and the rest of our budget comes from indirect cost returns and from tuition dollars. So we have modeled those cuts and do not anticipate having to do layoffs in response to those, and certainly are not anticipating doing furloughs in response to that. One thing that we've been, I mean, we're very fortunate in the school that we have pretty diverse sources of money coming in, and our funding streams coming from outside research have done well during COVID. I know that's not universal across the board, but the additional funding that we've received for COVID-related work has exceeded sort of other lost opportunities. So overall, our budget is looking pretty good. In terms of what the campus is planning to do, so the governor did announce that he will not be calling a special session of the legislature between now and the fall election. And what that means for us as an institution is that we won't know what the exact cut to the institution will be from the state in terms of our budget until after the election and the legislature reconvenes. So the current conversations that are going on are whether the university should sort of proactively plan on a budget cut of the magnitude that the Office of Planning and Budget had recommended. And that's going through our normal consultative process across the institution, where the provost and his staff talk with deans and chancellors, talk with faculty senate and faculty senate committees, and go through a consultative process in terms of what's going to happen. So we're currently engaging in that. But as I said, as of right now, things don't look like they're going to be super horrible for the School of Public Health, and we are not anticipating layoffs related to that. That being said, that, you know, it's possible that, you know, research grants that are ending or things like that, that there could be layoffs that are related to those, but not related to state budget cuts at this point. Uli, do you want to add anything more about that?
No, that's perfect. I don't have anything more to say. I wish we knew more info.
Yeah. Okay. Okay. So with that, and people feel free to pose additional questions. I'm sure we'll probably have some time at the end, and I'm happy to answer more questions. But with that, I think we can sort of shift gears and switch over to our conversation with Carey Farquhar, about her time at the WHO. And so I'll just start with the first question, Carey, so when you signed up for this 6-month stint at the WHO in Geneva, what was your intended assignment? Because I'm sure things change, but why did you originally set up the stint there? What was the plan?
Excellent question. So when I originally went, which was at the very beginning of January, my plan was to work with the HIV testing group, which is within the larger Department of HIV, hepatitis, and sexually transmitted infections, and work on HIV testing activities in West and Central Africa. I speak French, not as well as I thought I did once I got there, and especially with West Central African French, it's a bit different. Yeah, the goal was for me to provide consultation and actually be on the ground to some extent, supporting HIV testing guidelines and implementation of new testing policies in a variety of countries in West and Central Africa.
So how did those plans change in January when shortly after you arrived, a cluster of pneumonia cases were reported in Wuhan, China, and later, you know, progressed to the point where, this novel coronavirus outbreak was labeled as a pandemic?
And so for about 2 months, so the first 2 months from about mid-January to mid-March, but actually well before mid-March, we were thinking, talking, all of us, I think, around the world were aware of what was going on and anticipating big changes. But at least for the first 2 months I was going into the office, we were still focused on what we were doing within this group, within the HIV hepatitis STI group. We're focused really on HIV testing, but also different populations, key populations, and prevention, PrEP in particular. And then it became aware, we all became aware that many of the things that we were planning were not going to happen. And for me, I think the biggest one is that I was scheduled to go to the Côte d'Ivoire, to Abidjan, and early March, it was just canceled because Côte d'Ivoire said, no, we actually do not want anyone coming into our country. Sorry, all you Europeans. And there might have been a few Americans, mostly Europeans. And yes, and that was the, I think, big shift over to thinking more about these same topics, but in the context of COVID, which was one of the initial activities that we took on.
So any interesting sort of lessons learned being at the WHO during what's one of the largest global health issues of our lifetime, or interesting anecdotes or anything like that?
So, I went to WHO knowing a fair amount about them, being in the Department of Global Health and having worked extensively in East Africa and other parts of sub-Saharan Africa. But what, I think this opportunity enabled me to do was to integrate into a team. And I truly felt privileged to be a part of this group. They welcomed me. It's very bureaucratic, as one can imagine, with any large institution. So, it took a long time for me to get a contract and get a visa and so on. So it's a bit stressful on that front. But the people were actually absolutely incredible in terms of their just openness, but also in terms of lessons learned. I was just struck by how dedicated and committed they are to working with low middle income countries in Africa, Latin America, Asia, to promote better policies, better health, and ultimately positive outcomes that we all want. So that sort of struck me. Going one step further, I would say I was struck by just the scope of what this very small team was doing. How I ended up being quite focused on Kenya, for example. And here, this group of small individuals, they were having to have meetings and provide consultation for countries all over the world. And that's what they really took as their mission, and did a tremendous job with it, despite I think many shortcomings in terms of funding. So that breadth and scope, while one would say, well, the World Health Organization, of course they could do it. Maybe it was the ratio of individuals to the actual number of countries. Like, imagine trying to do what we're doing here in Seattle, King County, in multiple countries across the world, really all countries across the world. A big difference that struck me too, which I knew about, but it's different to be right in the middle of conversations where it's quite obvious that WHO and Global Fund approach the support that they provide in public health very differently from the US. And at least the US government programs. They very much promote country ownership, and they're there to almost to serve, to give advice, to help out where needed. But ultimately, the decision-making around policies and what's going to get implemented, that is at the country level, which is really where it should be. So again, being in global health, this is entirely consistent with how I also think things should be done. It's just not always consistent with how we do things, right? But being there, being an organization is there to give advice, assistance, support as needed, but not dictate what happens. And also Global Fund, of course, provides lots of money. One of my tasks was reviewing Global Fund proposals, which were in the sometimes $100+ millions of dollars for Democratic Republic of Congo, for example. And really just not a lot of strings attached to that, which could be good and bad in terms of outcomes, but ultimately, I think it'll end up in a more sustainable approach to these public health problems. Lastly, just comment on how truly evidence-based I came to appreciate WHO is, and that can't be said for all organizations that are doing this kind of work. I was within one department, but a very scientific department, and always looking to the literature. I mean, during COVID, I was fortunate to be on a WhatsApp group with the entire department where everybody was putting out articles, not everybody, because that would be too many, but certain specific people would be putting out the most important articles for the rest of the team to read, and then as they're commenting on them, and the various guidelines and different documents that we also were able to produce during COVID around what needs to happen with HIV prevention and care. Something as simple as you actually still have to sell condoms during this pandemic. You can't just suddenly say, oh, that's not essential, so we're going to kind of bar that off. So there were people paying attention to all the details and taking the evidence and putting it forward, saying, look, we need to we recommend that you act in this way. Of course, no forcing there. Now I'll just take one more lesson learned, and then you can pursue any of those that you like, which was that certainly within my group, but I would also say this was I worked also with the reproductive health group, which I will say was fascinating because they're more research oriented, and one of the University of Washington School of Public Health graduates, James Kiarie, who is a Kenyan, he heads the reproductive health branch there. So I had an opportunity to work with him on that. But between that department and HIV, hepatitis, STI department, it came to appreciate just how strong the social justice, human rights component of what WHO does, how strong that is within their actions, right? They're constantly thinking about how marginalized populations and communities, as well as countries, really are going to be affected by various things. So we had a number of times when documents were being put forward or presentations were being made just specifically on human rights violations, or the need to do certain things or make certain changes to ensure that there's equitable treatment of all. So I'll stop there. I'm sure there's much more I learned, but that's probably a mouthful.
You sort of preemptively answered a part of one of the questions from one of our listeners. So she or he also asked, can you comment on the role of the UW in developing the next generation of global health leadership in low and middle income countries, and and sort of the role that the WHO plays through that?
Right, so I touched on it when I mentioned James Carey, who was here in 2000. I think many people know James. And yeah, I think he's a great example of someone who initially trained at University of Nairobi as a obstetrician gynecologist, and then came and did a master's in public health here, and then has truly excelled. He's been at WHO now for 4 or 5 years, and I think they're not going to be letting him go anytime soon. Although I think he wants to go back to Kenya. So what is our role? So certainly, University of Washington is a well-recognized, really top-notch institution when it comes to leadership training. There are a number of programs within the Department of Global Health. Evans School has a program. I'm sure there are multiple others. Continuing to do that and to support individuals from low middle income countries to be part of those cohorts and gain the leadership skills they would then need to participate in the public health response that's really needed globally. The current Director General, Dr. Tedros, is pretty adamant about having WHO sort of represent the people working within WHO represent the world. So he has been quite active about recruiting more women into positions of leadership, as well as more individuals from the low middle income countries that I think historically have not been well represented, and yet there are hundreds of very highly qualified people in places where the need is actually greatest. So yes, so that's, I think I would say, continue training leaders, but not necessarily think of going to WHO, which is fine if you really want to go to WHO, but you have to do that as much as support, train, promote those who really are the most knowledgeable about the issues in their country and how to address them, and can communicate best with their people about what needs to happen, the behavior change, the various research questions, and so on.
So not surprisingly, Carey, we've gotten a question in a couple different forms, and one person said, can you please comment from an academic perspective on how the overriding political headwinds surrounded COVID-19 impacted progress or work at the technical level, and what health scholars like us can learn from how governments interface with the WHO?
Mm-hmm. So I think I'll start by answering.
Another person said very directly, can you comment on the withdrawal of the U.S. from the WHO, which I think is what the first person was alluding to. Yeah.
I like the way the first person asking the question phrased it, which is, how did it sort of interfere or impact what WHO was trying to do on the international front? And from my perspective, it was quite impactful, because it really was distracting. Like, when all of us should have been focusing on what needed to happen to help the world respond, all these different health systems and populations respond. Instead, there were all these conversations about U.S. is going to withdraw funding, and what does that mean for me? There are a number, as you can well imagine, a number of U.S. Citizens who work within WHO. The CDC in particular seconds many people to WHO, and all of them were distressed, distracted, including the leader of my team, right? And nobody needed to have that happen during this time when people are under so much stress anyway, just added additional stress. What do I think about it? I think I probably think similar to many of you, that it is not a good decision. The idea that the US would then step in and fill some gap was one thing someone put forward, which I think is absolutely ridiculous, because the US, I don't think, could ever behave in such an unselfish manner. The way WHO is not, from my perspective, and actually, let me say a full disclaimer that I've been at WHO for 6 months. So I am by no means an expert. So take all this, with my, that humble disclaimer that what I appreciated and learned just in these 6 months or so. But I do not see the US filling a void, and becoming some kind of a leader in pandemic responsiveness that is going to be, right from the get-go saying, okay, the countries that need us most are, Papua New Guinea and Cameroon, and we're going to jump right in and help them. No, that is unlikely to.
Well, particularly given that we're not doing a great job of managing the pandemic here at home.
Yes.
Right. Yeah.
Very true. So I think if that, was, what was going to happen, fine. If the other explanation is, oh, we can better spend our money at home, well, that's to your point, right?
Yeah,
We do need someone keeping track of what's going on all around the world, and making an announcement that there is a public health crisis of international concern, as was made, in January, and having people pay attention. I think it was very, very apparent to me, being in Europe, at a time when this was happening, and many of my colleagues were European, and people were sharing their news stories, their individual situations, crises, from Spain, from Brazil, from Europe, and here we're much more centered around what's happening in the US. So I appreciated hearing all of that, and really realizing that WHO, some people listen to WHO, some don't, some governments, some do, some don't, and depending on that and other, obviously, numerous other factors, the pandemic should have played out differently in those countries.
So on a personal level, what was it like being in an entirely different country than your home country when the world sort of locked down and travel stopped? That must have been interesting.
It definitely was. So, you kind of define like pre-COVID, post-COVID. So pre-COVID, the first 2 months I was there, we did a lot of traveling, saw quite a bit of Europe. My older son was there. And then post-COVID, just locked down the same as everybody else. One thing I enjoyed seeing was the response of the Swiss people to the lockdown. The Swiss and the French, because Geneva's right on the border, so many of my colleagues were in France and others were in Switzerland. We weren't allowed to commingle. Actually, nobody was commingling. We weren't even allowed to cross the border. But prior to that time, I had been kind of warned that the Swiss are very regimented and rule followers, and it was always told to me by my fellow Americans as a negative. I really came to appreciate that. It was nice to know that everyone's going to keep their 2-meter distance. People are going to wear masks if they're in a situation where they're going to stay home. They're not going to have their kids playing with other kids necessarily. So that was, I think, unique to being in Switzerland at that time. Things did open up there, I think, perhaps as a result of people being able to follow the rules quite stringently early on. Switzerland opened up, kids went back to school by, I want to say mid-May, the youngest kids at least. And that was also very interesting to be actually living one experience, but I always had another foot in Seattle because my husband and 2 other kids were in Seattle.
Were there parts of it that you felt like it was hard to be away at that particular time, either personally or professionally?
There were, and I guess I felt it most in kind of 2 areas. Not so much the public health one, I'll just say, because I feel like everybody here was doing a tremendous job. And I didn't feel necessarily I was needed there. I did feel, being an infectious disease doctor and hearing about the pressures on the university hospitals, and all of my colleagues in the infectious disease division having to kind of pick up extra shifts and hold pagers and this, that, I at one point thought I really should go back if this gets to a situation where...
right, because you're a clinician, you're not just a researcher and a trainer, yeah.
I should also be on the wards just like everybody else. So that was one kind of pang that I felt like. And then I guess the other really hard period, and I think all of us going through lockdown and this entire time go up and down, right? So my other super low was when all the racial protests, all that exploded and throughout the US, and I was watching those videos and just thinking, like, I want to be actually in Seattle also being a part of those protests. I did, I walked in the Black Lives Matter protest in Geneva, but it's not quite the same as being on your home turf with everybody you care about and contributing to something like that. So that would be the other part, the other.
Yeah.
Mm-hmm.
So we have a question in the Q&A box from Jim Guadino, who's one of our frequent participants and good question asker throughout this all these webinars. So he says he's been appreciating your perspective, and while you were with the WHO, where you're interacting with colleagues from the African CDC, and what else can you tell us about countries in Africa, particularly, I guess did you continue to be more involved in Western and Central Africa after you switched over more to COVID, or at that point were you sort of agnostic in terms of region?
Mm-hmm. So I ended up expanding out beyond West and Central Africa. I continued to review and have virtual meetings about a lot of the Global Fund proposals, and provide expert consultation on the HIV testing component in particular, but also the prevention treatment for the HIV TB Global Fund proposals that were going in, which is fascinating because I got to read. They were about 80-page documents, so I got to read about 10 pages just about the country and epidemics before then diving into what their plan was. However, I also worked more generally on two other projects. One was a chapter on promoting HIV testing in countries with high HIV burden post the ECHO trial, which showed very high incidence amongst younger girls, women who are seeking family planning services, and also showed that they were safe. So that was interesting, as well as now I'm working, finalizing a project with the Kenya Ministry of Health on their guidelines around HIV testing. So in terms of the CDC, Africa CDC, I personally didn't interact much with individuals in Africa CDC during my time there. I have in another context around one of my global health leadership programs, the Afia Bora Consortium for Global Health Leadership, which builds capacity in 5 countries in Africa. And so through that, I've interacted with them, and I know they were very, very busy because we had invited one person to be on a paper with us, and then he just got sucked away to do COVID.
And what COVID-related projects did you have while you were there? So
for COVID, I see the primary one, and this was early on, I would say, so in say April or so, was defining, what services and how one can provide services for HIV prevention, treatment, and testing in this new world we live in. So, just for example, something that's near and dear to my heart is assisted partner services, where if someone tests positive, we go out and we do essentially contact tracing to identify sexual or injecting partners. And then we test them for HIV, and it's a very effective way of identifying new newly diagnosed individuals, people who don't know their status and will greatly benefit from getting onto treatment. But you can't do that when there's a lockdown or when you're not supposed to be going out and knocking on someone's door and saying, you know, we've heard you may have been exposed to HIV, and you know, we'd love to offer you a test if you're willing and interested. So what we're doing is putting in guidance around that and then communicating that with the various regional offices, the Afro regional office and the other offices. And the same around, say, PrEP or HIV self-testing, saying maybe if people can't come to facilities, they can pick up a self-test for HIV at a pharmacy or in a place that's not, you know, as worrisome when it comes to transmission.
So related to that, can you see this first question that we have? The person is asking, could you comment on the push by WHO and PEPFAR to include extensive adverse event monitoring for HIV index testing and contact tracing? Yeah, anyway, can you comment on and there's more there, but I'll let you read it and let you comment on it.
Okay. I think I'll just go with what you said rather than try to open.
Okay.
I know we just have a couple minutes left, so that I know what that's referring to, which is actually pre-COVID, a lot of concerns around what I call assisted partner services, but PEPFAR calls index testing, which is the same thing that I just described. And a lot of concern around, honestly, I would say high targets that were set by certain organizations such as PEPFAR that resulted in provision of index testing that was either coercive, so saying you have to get this, or done in an unsafe manner. So someone says, no, I will tell you my partner, but please don't contact them, or whatever it was, and that happened. Or disclosing information about people. So WHO, and I was part of these conversations too, early on, was trying to kind of navigate this pretty difficult water to navigate around being responsive to these community concerns and facility concerns that were very valid, and yet also maintain that this is a super important way for people to learn their status. And where we were falling was, let's figure out ways to ensure that it's being done in a safe and ethical way, through training, through supervision, not through monitoring. WHO is definitely not promoting all facilities having to monitor in such a way that they'd be turning in reports every day. But those were some of the activities I was a part of as well, which was fascinating. Yeah, the politics as well as trying to do the right thing by community groups and the populations we're serving, but seeing a very big picture.
So we're down to our last minute. I'm going to ask you the closing question, which is, what recommendations do you have for students who are interested in doing either a practicum or internship or working with the WHO after they graduate? Any just words of wisdom there?
Right. So WHO has an intern program, and what I would recommend is applying through that program. Again, to be equitable, WHO does not just allow a student who has a insider track or knows someone to set up their own internship, which I think says a lot, right? They want everybody to go through the same process of applying, and then they can select, rather than me saying, oh, my great uncle's brother is there, therefore I'm going to get in and work with them. So that's what I would recommend. Just go online. We have a lot of University of Washington students who've done summer projects with them, or after graduating. I'm not ensure as many opportunities are available at that time. But certainly as a student, there are opportunities out there. And I'm happy actually to put you in touch with some of the students who've done them, but our wonderful coordinators in global health also, I think, know who those students are because they use them. They've done, had students do practica and things like that, for example.
Awesome. All right, so time's up, but thank you so much, Carey. It was super fun hearing about your time there, and I actually hadn't had a chance to get the complete debrief from you, so it's fun for me. We got lots of positive feedback from folks on the line. And for everybody else, thanks for joining us today, and keep your eyes peeled for email communications, and we'll see you again in 2 weeks.
Great. Thank you. Thanks, Hilary. Thank you, everyone. Thanks for listening.
Bye.